Hello, everyone, and welcome to the Practice Perfect podcast. We are here today. Oh, it feels good. I mean, I know the weather has been iffy in different parts of the country. We've had great weather, and then all of a sudden we had snow in the middle of the night last night. Maya, how are you? I mean, what's it like in Chicago right now?
We're expecting snow tomorrow. But you know what? At the end of the day, it's all by divine intervention, and we just have to be ready for it.
Exactly.
So
Just prepare. I mean, we know where we live. We know that it's never a sure thing, and we kind of accept it. This is the part of the country I chose to live in, right? So
yeah,
that's what I deal
not
with.
Hawaii or California because you're a California girl. So it is what it is. So we gotta make it work.
Yeah, speaking of California, I'm actually really excited. I got accepted to speak at HealthCon Regional in San Diego. So I am
Yay! That's
super
awesome.
pumped to be speaking in San Diego later this year in the fall. I do actually love California in the fall. It's really nice. It's like a really great time to be there. So I'm excited to go down there, see my family, and one of my best friends that lives there. We already have plans to go to a theme park and just have a good time. So
When I was
um
there for Hicker last year, there is a place called El Torino that it's right. Oh,
mhm.
yes, it's the best. And honey, it's like when you go in there, you feel like you're in a shopping mall because there's so many tables. It's like 10 tables full of food. Have you ever been there?
I've heard of it. No, I grew up a little north of there, and so
Oh, okay.
yeah. But no, I mean I've been there. It's just not I don't know it well, so I'm excited to get down there and just kind of be there and kind of the food obviously is
Oh,
just phenomenal.
yes, yes, it is. And I think that's another thing. The culture and the food is so different. Everybody is laid back. The food is more fresh. When you get to Chicago and in the Midwest, it has to go through a couple of changes before you can get to the right for food and the freshness.
So
So,
speaking of Chicago, girl, last night, well, my husband and I watched this show, and it's called Somebody Feed Phil. I don't know if you ever heard of it. It's on Netflix. It's really
oh,
cool.
wow.
So he's like the director or creator of Everybody Loves Raymond, and he's
Oh, okay.
married. He's married to the one who her name's Monica, and she was married to Robert on the show. And so she's really cool. So it's all about him going around the world trying food in different cities. So he went to
Wow.
Chicago and he was like going to different places. And I'm like making my list of places he went to that I want to try when I'm there with you in a few weeks. So we have to hit these places up that he went to just for fun. So anyway,
You mentioned
we
Italian
digress.
pizza. Yeah. Oh
Oh,
man.
yes. Yeah, gotta get me some deep dish, and I gotta get me, yes, a really good dog, and I just gotta experience Chicago. So we will do that. But
Yeah.
today we have,
Oh yeah.
oh my goodness, today's show. Are you excited?
Beyond, because this guest is everything. Like I've met her, and because I asked to talk to her for a couple of things that I was working on, and we hit it off, and she's amazing. She's amazing.
Well, we have a great topic today, which is right up her alley. So I want to welcome to the show Richelle Marting, JD, and let's talk to her. So we're going to bring her on the stage and we're going to invite Richelle to the Practice Perfect podcast. Hi,
There she
Richelle. How are you?
is
Hello.
in all of her beautifulness. Beautiful, beautiful.
Thank you.
So excited. Well, I
Yes,
know
thank you
I
for
want to
having me.
you're welcome. We are so happy you're here. And I want to share how I came in contact with Rochelle. So last fall, I was in St. Louis and I was attending the Denials to Dollar seminar from John Self and Carlene Dietrich. And one of your staff members was sitting right next to me. And we started chatting about stuff. And she mentioned how amazing it is to work with you. And I thought, well, I got to meet this lady. And so I connected with you online. And here we are.
That's right. And I think Maya and I's story is fairly similar to that, connecting through LinkedIn and
Yeah.
meeting each other that way. Yes.
Yeah, yeah, because Richelle Marting is the guru of Medicare Advantage. Oh my goodness. So yeah, we had some conversations with regard to that, and yeah, that conversation resulted in some things that I may have to share later.
Yeah, I agree. So what I'm thinking about today is our audience is probably very well versed, most of them, in what Medicare Advantage is. But let's just share with the world, just so everyone can remind themselves, why are Advantage plans, so Part C Medicare, why are they different? What sets them apart from traditional Medicare? So, Richelle, if you can take our audience through that, what's the difference between Advantage and then the regular Medicare?
Yeah, and you hear them called different terms: Medicare replacement plans, Medicare Plus, Medicare Advantage, and I like some of those Medicare Plus vernaculars because that's really what they can be. They are supposed to be traditional Medicare benefits with the ability to get supplemental benefits and to have things covered under a kind of Medicare based plan above and beyond what you would get from your traditional Medicare benefits. So things like a well woman exam, a well male exam that traditional Medicare does not cover. These Medicare Advantage plans can cover those enhanced benefits on top of what someone 65 or older eligible for Medicare would be able to get through your regular fee for service direct Medicare plan.
Excellent, excellent. So then we think, okay, well, we expect that when we get a service from an Advantage plan or Part C, we expect that they should follow what Medicare lays out. I was actually doing a little digging, and I know most patients, they get a lot of their information. The Medicare.gov website is really designed to give patients information about Medicare. And they specifically tell them if they want to know more about Part C plans, it says here that you can join this Part C if you have Part A and B, and it's offered by Medicare approved private companies that must follow rules set by Medicare. And that's the part that I go back to, and it's in the law. And I went to Dawn's seminar, so I'm like remembering all the stuff we talked about. It's in the law, in that law there, and that one section that just goes over all the things that they're supposed to cover, they're supposed to do. So where do we see nowadays, Richelle? Like, are they following through in the rules and regulation they're supposed to follow?
I think that is one of the biggest challenges that providers that are working with Medicare Advantage plans and patients and consumers for that matter face. Because one of the key differences is that Medicare Advantage plans can use prior authorization processes. Traditional Medicare could, they just, with very narrow exception, do not use prior authorization. And so access to and coverage of and payment for all those basic Medicare benefits, I think is, if I could kind of condense it down to one challenge, I think that is it. Prior authorization challenges really boil down to whether they are covering and paying for basic Medicare benefits. And you're right, Jennifer, it has been in the Social Security Act where the Part C provisions were initially passed by Congress since the inception of the program, that Medicare Part C Medicare Advantage plans must cover and pay for all of the same basic benefits as traditional Medicare. It's in regulations, it's in Medicare manuals, but it gets a little bit fuzzy when we say cover and pay for those same Medicare benefits. For example, does a Medicare Advantage plan need to pay for those services at the same level, like inpatient or observation? Do a level 5 visit versus a level 4 visit? Do they need to pay the same number of units? And that's where I feel like the rules have sort of become convoluted and there's disagreement across the industry on what that means and how it's applied. Providers have one perspective that I think we would say Medicare Advantage plans must pay for at least the same number of units, at least the same level of service as traditional Medicare. And then we see Medicare Advantage plans sometimes taking a different interpretation.
Exactly. And so I think this is one of the biggest issues. And just on its own, prior authorizations, regardless of it's MA or commercial, they're just a problem. They're limiting patients from getting care that they should receive. And like I said, I just spoke at RevCon last month on this topic. And so what I tried to do in that presentation was really walk people through what you can do. because a lot of medical practices, even though they are doing their best, they may not have the best process when it comes to doing the actual authorization process. So let's talk about that for a minute. So Maya, why don't you walk us through, in general, how does one go about starting an authorization process? What are the steps they would need to go through? Oh, you muted.
Don't have any noise in the background, but it's all about
There you
planning,
go.
right? Pre-planning. You know, you have to know the procedure that's going to be performed. You have to know the reason why, the medical necessity. And then there has to be a process of which the provider's office needs to call and making sure that they are in line with coverage. Typically, there are some sort of medical records that are sent, the diagnoses, the procedures, everything that's associated with that. And you know, once that information is sent, the prior authorization should be approved. The number that is utilized or assigned to them based upon that pre-authorization is sent on the claim. And with that pre-authorization on the claim, that's what they should use ideally to pay the claim. But that's not always the case for some reasons.
Yes, I agree. And then I also think too, even if a practice does everything right and they get the number and they tell them the codes, there's always nuances. Like I work in the surgery world, and when I call for authorizations in the past, I would have to give them a series of codes because we never knew what was going to go on in the OR. If it was like an orthopedics is where I work mostly, so if there
Right.
was a arthroscopy being performed, we would have to make sure that we covered all the bases. We know that if he's in the shoulder, there's chances that these three codes are always going to be there. But we always wanted to make sure we talk to the physician just to make sure these are all the potentials, right? And then we kind of get to know them and we know, well, usually they also do this, this, and this potentially. So we try to cover everything. Doesn't
Right.
always work because some payers, like our Medicaid locally here in Arkansas, they get very picky about how many codes or if it's exact. They don't like to you to give them everything. They want to know exactly what you're trying to authorize. So some payers won't even let you do that. So you're kind of at their mercy. And this is true with Advantage plans too. You got to know the benefits, you got to know their policies, but they make them sometimes hard to interpret. And I find that to be true. What do you think about that, Richelle? I mean, do you find it to be true that even just accessing these policies, accessing these rules can be difficult for most practices?
Yeah, so there's a component of accessing them for purposes of knowing when prior authorization is required, and you're right, it can be sometimes a digit in a code that makes the difference, yes or no, right? Simple or complex potentially. That's a challenge, and then it's really a challenge to understand the coverage rules that the payers are outlining, and if prior authorization is denied, should it have been denied? What would Medicare say about that same service under those same situations? And we got some really good guidance from CMS in 2024. I keep wanting to say earlier this year, but it's 2025 now. Beginning in January of 2024, that really honed in on when prior authorizations can be used by MA plans, what they can look for, when they must approve, who must make decisions. So, some really good guidance refining the process specific to the Medicare Advantage program.
Yes, exactly. And then previously we did have that final rule of their plan to, I guess you could say, bring everyone together, so to speak, and try to streamline the process across, just data exchange, making sure that the one thing that I loved about their plan that's going to be phased in next year and then in 2027 was thinking about patients who change plans. So they get an authorization in November of certain year, and then the next year their plan changes. So this authorization should still hold, hopefully, over a certain period of time if it transitions from one plan to the next. And I think that can be a huge problem. We dealt with that in plastics all the time when we would try to get the breast reconstruction or those procedures, actually approved. There's a lot of different things. Some things were you had to authorize, some you didn't. And then when it came to the patient at that time of year, they're scheduling, and then they get to the next year, it's a different plan, and we have to start all over again.
You know, one of the things that I found in my experience in Medicare Advantage is and Richelle mentioned this, is that, it's individually run by the commercial insurance payers, but they're not following the conditions of participation for Medicare. They're following the contractual agreements of the commercial insurance carrier. So, a lot of times, in my experience, the contractual agreements between the provider and the insurer, it becomes very confusing because they don't know which conditions of participation that they're following, the Medicare or the commercial carrier. And then there are some exceptions that are related to how that contract is outlined. So providers who are involved with that piece should be very well aware of what they're signing to when they agree to see Medicare Advantage patients.
Yeah, and you're right, Mai. So what I often see in contracts is a reference that participating provider will follow the plan's policies and procedures,
Yeah.
right? And unlike your contract, which typically has to be amended with everybody signing, on ink or virtual ink, policies and procedures can be created and reviewed and revised periodically, unilaterally by the plan. So we've got policies that could potentially change throughout the course of the contract. However, also buried in that contract is usually language that says we'll comply with applicable law. Applicable law for Medicare Advantage means the plan has to cover and pay for basic Medicare benefits. While they may be able to create policies and modify policies over time, they cannot be done in a way that is more restrictive than what traditional Medicare would do for the items or services that are governed by those policies. And Jennifer, you had asked about, is this hard to find the policies? Let me tell you what I spend hours and hours a week doing, reviewing announcements of plans, new and updated policies, and reviewing them to understand, do these apply to Medicare Advantage? If it applies to Medicare Advantage, what are traditional Medicare's coverage rules for this particular item or service? And then I compare that plan's policy to see, is it more restrictive than traditional Medicare? And then we exercise some processes under a contract to, communicate concerns. And there are lots of other enforcement mechanisms you can do too, but that step it can be hours and hours a week of reviewing and coming through hundreds of policy changes for the plans that you're seeing on a regular basis.
Right. And so it's a lot of work. It's convoluted at times. But let's say, for instance, there is a policy out there. They've identified that this policy is restrictive based on that language. What would be their next step? So, for instance, they could contact a healthcare attorney like yourself, or who would they contact at the plan, or how far would they go up the chain? Who's the best person to contact to make this known, basically?
Yeah, well, that often depends on the contract. That's what they told me to say the first day of law school. It depends. But it depends on your contract. So typically, there's language in your contract that you can express concerns or object, whatever terms they use, when policies or procedures are created that the practice has concerns with. And there's a notice process, and there's a place that you send notice. And it seems really nitpicky, but you've got to follow that process to a T. And there might be timeframes involved when you need to communicate that notice. So there's a notice to the plan where you say, we've reviewed this policy in your recent announcement, we've got concerns, and you kind of cite back to your contract. So that's sort of step one, memorializing that concern. Now, because we're dealing with plans, Medicare Advantage specifically, that might be governed by the Social Security Act and regulations, if you're not getting a response or feedback from the plan that you're satisfied with, there are mechanisms to file complaints to CMS. That has become a little bit stronger process in the last 8 months or so, where providers can now use a process similar to what patients have always been able to access to complain against a plan, and it counts against the plan's star ratings now, that's a big deal. They're very aware of star ratings and any impact to those because it impacts the plan's payment. There are also CMS points of contact that you can reach out to express concerns or questions when you think Medicare Advantage plan policies may have the effect of being more restrictive in terms of accessing items or services for that patient than what traditional Medicare offers. And I'd say, I don't know, fingers crossed, or we'll kind of watch the calendar. There's a proposed rule for 2026 that would take it a step further on prior authorization and coverage policies for Medicare Advantage plans, and reporting and notifying CMS to make sure that they are in line with traditional Medicare requirements.
I know that's gold right there. I mean, like that's huge. And I think uh, the struggle is real, and they realize that they have to do something to hold these people accountable. Now, in recent months, I know last year Humana announced dropping their commercial side, and there has been talk about them dropping their Medicare side. So, what have you heard down the pipe about Humana, for instance? I mean, like there's a lot of changes there. Have you heard anything specifically about how that's impacting people?
Yes, well, Humana's nationally one of the larger Medicare Advantage plans, and geographically where I am, they are one of the larger plans. We've had several major carriers in their Medicare Advantage products in our area. So there's certainly one that's remaining, but you see them shift focus from employer plans and commercial plans into government plans. So Medicare Advantage is a huge component, potentially entering into different Medicaid, MCO RFPs in different states as well. At the same time, it seems like weekly there's a headline about Humana exiting certain markets, even for Medicare Advantage, where their plan it has not been profitable. So it's hard to gauge. It's you don't see them doubling down necessarily and going full steam ahead in Medicare Advantage, yet it remains one of their biggest product lines.
Right. And so I think when that was kind of a rumor, it was during the open enrollment for a lot of course, people. And so my grandparents, they called me and they want to know, what's going on because they're about to choose their Medicare Advantage plan. So, I always advise that they talk to their insurance representatives and give them advice. I know I try to stay away from giving them too much advice because I don't want to sway them either way, but have them do their research. A lot of people out there have spoken publicly against taking these advantage plans and going back to traditional Medicare. And so I get that whole desire. But I also see that some of them have benefits. I know on the risk adjustment side, one of the huge benefits that some people take advantage of, let's say, for instance, they're diabetic and they have to have their medication. It needs to be in the refrigerator, right? Well, if the refrigerator breaks, there are some plans who will buy you a new refrigerator. Like to some people, that is like a huge thing. So there's a lot of cool things that they do for their members. But then you think, I have to weigh this cool thing with the long-term, benefits of, are they going to cover what I'm going to need? And so
Exactly.
when you talk to patients, like if you were to talk to a patient as a legal professional, even to your own family, what advice would you give as to what to consider when you take on a plan? What should people look for?
Yeah, well, I think one of the challenges for consumers is the stability of the plans. And if you have a long-term provider that is your primary care provider, or this is your hospital, you also see weekly in the news different professionals going out of network, hospitals going out of network. And I think it creates a lot of uncertainty for patients. If that were to happen, will they be able to continue to see their provider? Now, there is the benefit of annual enrollment where you could switch Medicare Advantage plans. So that's, I suppose, one plus is that you can switch back and forth. But once you go from traditional Medicare to Medicare Advantage, it does become a little bit more difficult to go from Medicare Advantage back to traditional Medicare and to get a supplement plan. Now, I hear a lot of brokers say they would either recommend Medicare Advantage or traditional with a supplement. And part of that, if you go straight into traditional and get your supplement, I believe, there's no underwriting initially. But if you go to MA and come back, then there's underwriting, and depending on chronic conditions, that might impact the cost of going back to traditional Medicare. So there's a lot to sort through, prior authorizations and lack of access, but then those cool benefits, like if I need a refrigerator for my medicine, plans that help make sure that that's available. And there's pros and cons both ways.
Yeah,
I
and
think so
another
too.
drawback for that is, the cost for the supplemental versus the cost that's associated with, the Medicare replacement policy in itself. And in advising my mom and, my, everybody, because we're in healthcare, we know, and they were, well, this plan costs me this much for per month, and this plan costs this much per month, and how and what and how come and what if, and you're like, I don't have the answers to the world, but I can tell you that the answer should be what's going to benefit you more. Mom, you have this, 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 and this. This plan offers this if you do this. So, the granularities and reviewing all of that, like you say, Richelle, is very time consuming, especially when you're, reviewing the conditions of being a patient, when you
Yeah.
sign to be on those types of plans. So it's all going to be about cost, right? And some people only have Medicare A because that's the only thing that they can afford, right? But
Mhm.
it's really a very convoluted market, and it becomes very confusing when people have perceptions versus understanding the truth about what they sign up for.
When you see a
Right,
lot of
yeah.
Medicare Advantage plans advertising zero premium, and when you're on a fixed income, that is really tempting, right? To not have that monthly premium for your health insurance. And that could work, that probably works really great for a lot of people. When and if you get sick, when and if you need hospitalization, just the anecdotal of this is not from a national study, but just anecdotal from a couple of organizations. We find the out-of-pocket cost for individuals who have Medicare Advantage when you need services in the ED or the hospital is about 6 times more than traditional Medicare. So you are getting that cost at some point, and hopefully you never need it. But when and if you do, you're kind of getting hit with that cost at the worst time, when you are sick, when you are not well, and when you're particularly vulnerable.
Right, right. I go back to my grandfather in 2014 had a stroke, and he had to go through speech therapy and different things. And that's really, his body didn't really like suffer. It was more his speech was the thing he had to learn again. And it was just crazy to see someone that was so, vocal, and he could not even remember how to say words, and that was so heartbreaking. And like, I remember the whole time period just going through that. But then on top of that, my grandma didn't realize that every time oh yeah, every time we go to therapy I have to pay a copay. And so that is a little um, frustrating for patients when they didn't expect that, right? The plan has a copay, but they don't really anticipate having to use certain benefits until they do. And now they're stuck with a copay every visit. I did therapy, billing and coding for a while, and a lot of patients couldn't pay three $45 payments a week. So that's a lot of money. And so they would not pay. And unfortunately, some of the practices didn't want to lose patients, so they kind of violated the copay rule and just let it slide. And so, which is also a no-no. But how do you like, that's just a hard rock and a hard place, in my opinion, for the practice and then the patient. Like, so what can we do about this? Is there anything we can do to be more efficient in this area?
Yeah, what's another example of prior authorization? Are we getting prior authorization for a certain number of services, a certain number of units, right? Like how many units per day? Could we have longer sessions, fewer times a week, to help the patient with fewer instances of a copay? And it's an example that's one specific example where I've seen some MA plans limiting the number of 15-minute increments per day that can be billed below what traditional Medicare would cover for that exact same service. And the rationale from my perspective is you're not covering that benefit, that 2 hours, that 4 hours, that 8 hours that regular Medicare would cover. Then the plan's perspective is the benefit is speech therapy. We are covering the benefit. not necessarily the same number of units or to the same extent. And that's where I think there's a discrepancy. But perhaps, Jennifer, depending on the practice area, you kind of know your specific Medicare Advantage challenges, like frequency of visits and copay each time, to try to work with the plan. Ultimately, it's best for the patient to get what they need, and see if we can accomplish that in fewer visits that might be a little bit longer, in that particular instance, to reduce the frequency of co-payments for them.
Right, right. And I think going back to just the beginning of all of this, it used to be called utilization review. And I remember way back in the day, I would tell my gastroenterologist I work for, because at that point they weren't requiring authorizations for colonoscopies. And it was they kept sending them off with unspecified abdominal pain. And I kept telling them, I was like, I foresee this being an issue one day. I saw it on right on the wall. I know how insurances work. They're going to at some point start authorizing this service if we keep submitting it with unspecified abdominal pain. Lo and behold, we had an LCD that came out finally, and then the authorization started. And so I saw the writing on the wall many years ago. And so I think that progressively, nothing's not that physicians are completely to blame, but I think there's a disconnect in communication with the reimbursement teams and the physicians. If they knew more about how the decisions they make today could impact utilization standards and authorization potential down the road, they might really try to improve their documentation and the reimbursement strategies that they employ. What do you think about that?
Yeah, I mean, and I think that that knowledge and understanding of maybe the circumstances that traditional Medicare covers, and sometimes it's a linkage, right? So the patient may have a unspecified abdominal pain, but there may be something else, and it's already there, it's already documented, it's in the problem list, but we're not capturing it in the prior authorization process. But we need to, and we need to know what to capture, by knowing what the traditional Medicare requirements are that would consider that service medically reasonable and necessary.
Right, because if they're getting like 50, surgeries being billed, or so many per provider, they're gonna maybe think, okay, well, we're gonna need to try to control the cost on this. So that's usually why prior authorizations come into the mix. They're trying to control the cost of certain services, where before they didn't have an authorization requirement for it, and then all of a sudden now it's on the list because they want to control the cost.
Right.
Mhm. Yeah. And what I find also is very interesting is when you think about it from the patient's perspective, oh, you need this service, but we have to get it pre-authorized. And then you give this 65-year-old woman who's wearing reading glasses on top of her other glasses this information that they have to go over and make a decision there. And I think, uh, from the perspective of advocacy, and because Jennifer, you're all about that. There has to be some intermediaries, if you will, to help explain this in a manner that's understood. And a lot of times, patients are forced to make decisions right then about how to proceed, what they need to do, that kind of thing. And it becomes so overwhelming that they just sign and go for anything and succumb to what they're told to do rather than making an informed decision, which is really bad.
Yeah, and it's
Yeah.
I kind of think back to contract language, right, where plans also require that we participate in their utilization review, utilization management program. And at the same time, they typically clarify that while they have utilization management processes, the plan is not ultimately responsible for the care that is delivered to the patient. So providers getting a denial, who really believe that this item in or service is medically necessary, need to understand the appeal processes, and educating the patient that this doesn't mean it is not medically necessary. It means it may not be a covered benefit, but you still really need this service.
Right.
Mhm.
We have ABN forms, we have other financial agreements we can give them. And I always advise practices, because I do obviously have advisory service myself with our clients. At the end of the day, it's a business, and you have to keep your doors open so you can keep serving the community. So if you are proactive and you understand what's covered, non-covered, you can let your patient know you need this, but the only way to get this covered is if you pay out of pocket, or we can help you with some financial assistance. So making sure they know of the options, because there are options out there. I mean, there's charity care programs that most or hospitals have to actually offer. They don't make it easy to find, but they are there. And so being proactive, having patient advocates, you can hire a private patient advocate. The hospitals have patient advocates to help them find the resources that they need. So everyone needs to work together, because it's all about the patient. I mean, that, and I'm a patient advocate, so of course I'm coming from that aspect. I love it, but there's so many pieces. So let's review. We definitely know there is a problem with the insurance companies following what they're supposed to. But on the practice side, we still have to follow compliance. We still have to submit claims in a compliant way. And it's, of course, in your best interest, right, to make sure the patient knows how that impacts them. So from a compliance standpoint, Richelle, what should practices know, and what should they kind of be aware of as they navigate this process to stay compliant?
Yeah, I think a great tip, and we always talk about documentation when we talk about compliance, but if a prior authorization, if a request for services is denied by a health plan, there's sort of, I think, a supplemental informed consent process, right? So it's been denied. Now what? We still recommend you get the service. Do you document that you've educated the patient on the right to appeal? Obviously, they're going to get a copy of that as well. Do you go through the appeal process? But I think some sort of close the loop documentation or note in the chart, so you can see what the physician, what the providers did with that denial. And if the patient ultimately decides not to get that colonoscopy that was not prior authorized, and that has a bad outcome later on, then there's documentation to say we recommended it. We urged the patient to still get that service, even though their insurance wouldn't cover it.
Right. And then we have the other caveat where they're overworked and they don't figure it all out in time, and they go in and have the surgery, and they can't bill the patient after that because there was nothing in place. They basically can't. They try though, yeah. They try to bill the patient, but yeah, I mean, like, they didn't follow those steps either, and now they've hurt their practice. So I think it's 100% important for you to make those documentation notes. Be proactive. It's denied, so before it happens, make sure the patient knows and can make a decision whether or not they want to go forward with it. Because once you do it, and it's the patient is not liable if you decide to go forward with it and you don't notify them. So there's things that you want to be aware of on that end. But I mean, like I said, efficiency is really important. So you can reduce a lot of your administrative burdens if you understand the process. And like you mentioned earlier with the contracts, hold them accountable. Don't just sweep it under the rug and just write it off. If you can potentially make them accountable, you should, I would think.
Yeah.
And providers have a really good success rate when they appeal prior authorization denial. So I really encourage practices to not take the first denial. And if they have an opportunity for peer-to-peer for a quick turnaround, or to exercise the appeal process, or help their patients navigate a member appeal, which often are more successful than a provider-initiated appeal.
Right.
Yeah, that's very powerful.
I would also say, though, providers' offices should take the time, have someone delegated to take the time for those types of things, because bandwidth could always be an option. Bandwidth with the offices understanding that. And if there's no one there to help navigate that process for the patient and or for the provider, then everybody's going to lose, because everybody is losing money, whether it's the patient who has to pay it or the office who has to write it off. So understanding the delegation process of someone who is interpreting that on the patient's behalf and the office behalf is very important.
100%. So yeah, I think we've covered a lot today in our time, and I am so happy. I know, I can't believe it's time to say goodbye, but we really have enjoyed talking with you today, Richelle. And for those of us that need to get some legal advice, where can our audience find you?
Yes, well, the email address and the website is really easy. It's rmarting@richellemarting.com or just www.richellemarting.com.
Wow.
Excellent.
Also
Beautiful.
on
And
LinkedIn, which has been a great connection for the three of us. Yes.
I
absolutely.
know, right?
I look forward to every time you post something, Richelle, because it's so insightful, and you just elicited a lot of comments too, and people just responding, and it's great to see
Well,
the back
yes,
and
for this
forth.
question, that could be a great place because I do often post about things that are just kind of going on in my
Yeah,
world with Medicare Advantage and that are changes happening or FYIs for people. So that's a great place to stay in touch as well.
Yes, LinkedIn is a
excellent.
beautiful place. Yes, it is.
It has brought all of us together, so it's a great thing. Well, thank you everyone for listening today. Thank you to our wonderful guest, Richelle Marting. We hope that you'll join us next week. We're going to talk more about actually auditing. We're going to dig into auditing next week. So we look forward to having our next guest on next week. Stay tuned for that and have a great rest of your week, guys. See you later.